Ladies and gentlemen, dear colleagues, now it's exactly 3 p.m. in the afternoon in Vienna, Central European Summertime, and we start our webinar about sonography of the abdomen part 2, because we had already one webinar, part 1, sonography. I'm together with Martina Scharitzer, Alexander Sachs as radiologists presenting the cases, and Alexander Hirsch is our Chief of the Technical Equipment Organization, Evelyn Simek, and Video Documentation, Caroline Kobo. We welcome you together with our team and would like immediately to step in the webinar. So what has to be said in the beginning, that after the presentation of cases we will start the quiz, and you can give us the diagnosis directly into the chat, and the first correct answers will win interesting book from University Publisher 3.0, a publisher from authors, from a big authors group sponsoring this action, which is a non-for-profit action together with the College of Physicians in Vienna. So the cases we will show to you as well should be discussed within the chat, and we will just start immediately with our tutorial. Our aim is to learn about basics of abdominal sonography, so the level would apply to students and young doctors more or less at the beginning of a professional career. So we try to stay on a basic level, but nevertheless radiology is very difficult and even the basics can raise some discussion. Well, interactive discussion of cases, we will concentrate on the imaging workup of findings and diagnosis, and especially of your contribution by chat diagnosis or any kind of question you have or any kind of idea about these cases. Just share that with us over the chat. So the first case is the classical clinical problem in abdominal ultrasound, and this is the routine. Usually patients from just wake clinical settings, or if they have just the idea to have a workup to maintain health or whatever, they get or undergo sonography of the abdomen. So very often we will detect disease accidentally. This is a 65-year-old woman, and you see the right liver lobe in an oblique cut, and the right image is just a sagittal cut from the left lobe. So I would be very happy to have your suggestions within the chat. So just think what's going on here. Do you see findings which could be of concern, and what would be your suggestion? These are simple and common diagnoses, but in this case not that easy.
So first idea is this could be a steatosis of the liver.
Yes, of course. Yeah. That's a very good suggestion. And are there other suggestions?
Another suggestion is focal nodular hyperplasia. Then we have a third one which also goes for steatosis.
Okay. We have here two little rounds, and here a bigger one in the left lobe, and we have here, as the colleagues stated, indicative for steatosis, somewhat hyperechogenic tissue. So let's just go a little bit back. As I told that Very often this is a routine examination in a general workup, and accidental sonographic findings of liver disease can be done beside routine. Often we find something during workup of trauma, where parenchymal bleeding of liver, spleen and kidneys has to be excluded, or free fluid in the abdomen, and after care, after tumor treatment. If there is evident or suspected disease, it comes from the history of the patient, laboratory findings, or maybe just by findings of CT or MRI. Going back to the sonographic report of the liver, we have to look for the liver size. Usually the liver doesn't exceed 15 centimeters craniocaudally, and the relation to the kidney means that the normal liver doesn't exceed the range of the lower pole or the level of the lower pole of the right kidney. Especially in slender women, sometimes the left lobe goes deeper than the right kidney and is a little bit more thickened, and this is a variant, but usually the liver should stop before we see the caudal pole of the right kidney. Then the shape and outline is very important. If the contour is smooth, and of course the shape includes if there is, for example, a big left lobe, as you see in alcoholic liver disease, and there are some others. The general echogenicity, the colleagues stated as well that there is steatosis in our case, and the general echogenicity always has to be considered and included within the report. Very important, of course, is to search for local pathology. It's not only liver lesions, can be as well something pathological from the vessels, or of course our famous gallbladder, the surrounding structures, important, for example, free fluid between the liver and the right kidney. So let's move on to this case. Do we have...
There's a question in the chat regarding nodular hyperplasia, and it is if there's always a focal scar present.
No. So this is a good question indicating the drama of macromorphology. We are almost always in troubles if we have to define histology, but there are some very classical and common findings, and usually we accept them as being a fixed diagnosis. Focal nodular hyperplasia does not belong to them and needs usually further workup with CT and MRI. Maybe Martina would like to state something about focal nodular hyperplasia?
You can see the central scar best with MRI, especially if you use a liver-specific contrast agent, and then you can see at the beginning not enhancement of the central scar, but then in late phase imaging you can see enhancement, and then it's better to delineate this typically central scar, but in ultrasound, of course, often you cannot clearly depict it.
So this, of course, brings me to the interest. So it was a good explanation, Martina. Maybe you would like to show that.
Yes, here you see an example of focal nodular hyperplasia, and on the right upper image you see the pathological specimen, but on the left side you see MR images, T1 and T2 weight, and there you can see this big central scar, and you can also see the different enhancement pattern after administration of contrast agent.
Beautiful images, and they are from our textbook of clinical radiology, and it's always with us. The publisher grants us that we can use it for our webinars, so that if there is a question we try to move on into our chapters and to show that directly. So back to our case. When we look at this image we see many different things. It's true that we have an inhomogeneous hyperechogenic liver tissue, but we have 3 rounds. So we have hyperechoic liver lesions. And so we have 3 small, a little bit above 1 centimeter in the right lobe, should be at the border of the caudal and cranial segments 6 and 7. And in the left lobe there is a larger one, a little bit more than 3 centimeters. And what these lesions could be? Is there any suggestions?
No, not yet. But let's give them some time maybe. There's an idea.
Is there any idea about a hyperechoic round lesion in the liver? I will help a little bit. The left ones are typical, classical.
So a suggestion might be metastasis.
The good suggestion for this one, because of the poor echogenic halo, but the left one, what is the differential diagnosis?
Adenoma.
Adenoma. And what is the most common tumor?
Hemangioma. Another one. FNH is another one.
Okay. So let's move on. Now we have hyperechoic liver lesions, and as already stated, an inhomogeneous hyperechoic liver, and the inhomogeneous hyperechoic structure is combined with poor echogenic areas. What you cannot see on images, but what was possible for me to see during dynamic sonography is that the poor echogenic areas, they were not rounded lesions, they were just inhomogeneous structure and couldn't be seen twice in sagittal and oblique views. Always you have right-angled planes to define a lesion, and the hyperechoic lesions could be seen in sagittal and oblique views as well. So we have these 2 different things in one case, but this is not very rare because the fatty liver is a very common diagnosis as well as these little rounds. So altogether we had as differential diagnosis hemangioma metastasis for a focal nodular hyperplasia. Of course, it cannot be ruled out, but this wouldn't be common to see them as hyperechoic lesions. So in this case, that had been typical hemangiomas already with a follow-up of over 5 years, and they are represented usually as small little rounds between 1 or 2 centimeters. This is the most common finding you will see in sonography of the liver, just hyperechoic, somewhat homogeneous little rounds. And if they are more atypical, more larger, the classical finding to be sharp without an halo is almost lost, and you will see later on how the hemangioma behaves in CT and MRI, because these are the classical settings then to do a further workup. Very nicely, you see here the portal vein, liver veins, and bile duct, and here a triangular hypoechoic area, which is not sharp, but it is defined as well as these hypoechoic areas, and these are lesser fatty areas of the liver. So this is an inhomogeneous steatosis, a very common finding, and for the first view it looks somewhat much more dangerous as it is. A very common finding. So, there have been valuable contributions in the chat, and we are thankful for them. And we will move on to our next case. Now, we remember that we have to look for the liver size. This is a right oblique view. There we cannot estimate the size of the liver. The shape, I would say, is not reflected very well by such a cut. To see the shape, more coronal views from the median orientation are very helpful, and sagittal views to see the relation to the kidney and the other organs. General echogenicity, well, that's maybe of interest here. Vessels we don't see. Surrounding structures, I don't think too much. Again, we have a local pathology, and here we should more specify how these finding should be called. What would be your interpretation? So we are waiting from the chat.
Nothing yet.
So is this hyperechoic, anechoic, or hypoechoic?
So first answer is hypoechoic.
That's true.
Next one says it's roundly shaped and hypoechoic. Again, two more answers which go for hypoechoic.
And how's the outline, the delineation? Sharp, unsharp, red?
Unsharp. And the other one says sharp.
Well, this is difficult, of course. But a sharp lesion would delineate a little bit better. It is slight inhomogeneous, I would say, but the description was quite well. So let us have an idea about what that is. This is a 2 centimeter round liver lesion, hypoechoic, with unsharp margins. So I would be interested about the differential diagnosis. What would be a good idea about?
One says that it could be a cyst or metastasis.
What kind of cyst? A cyst would be completely hypoechoic. Alexander, would you give me the paper? Because I would like to make marks what I should, after this case, immediately showing in the book. Okay. I can tell you straightforward, if this would be a cyst, it should have very thick fluid, protein-rich fluid within, because a cyst is usually anechoic, which means black in ultrasound.
There's another answer for AV malformation, or inflamed cyst, or again metastases.
Okay, metastasis is a good suggestion, which means secondary malignant tumor. Of course. What do you think, Martina, what would you think about an abscess?
I just wanted to say, in fact, a cyst is a suggestion of an abscess, and of course a liver abscess can look like this. Probably you see more edema around the lesion, which I cannot see in this specific case, but you have also a hypoechoic lesion with unsharp margins.
Yeah, and if abscesses are that small, they could be deriving from a bile duct infection, and so there would be more of them, like grapes, because the bile ducts are branching and usually they have more than one abscess. But of course this is a good suggestion, and can be seen sometimes. What do you think? There is one differential diagnosis missing.
You want me to give the answer?
No, the chat. You know it. Maybe you don't know what I mean now, as I wouldn't know if you would tell me the question. But we had metastases. Is this the only malignant lesion?
Suggestion it might be a primary liver tumor.
Yeah. Which one? Nobody knows, of course. Suggestions?
HCC.
Of course, yeah. The most important suggestion?
Adenoma, CCC, HCC again.
And always, almost always.
Might be metastasis from a colon cancer.
Yeah, of course, it's a very good suggestion. And always, if you are in a differential diagnosis of a tumor, you can mention lymphoma, because this is at last this tumor able of producing almost every kind of morphology, as well in inflammation is tuberculosis. These are the two tricky diseases. Okay, so I think that that was said much about this lesion, and it is indeed a metastasis. But as we heard from the colleagues, true differential diagnosis indicating a lot of different diseases, sonography is very often the first line detecting a lesion, and then the workup with CT and MRI is crucial, especially for difficult hemangiomas, as well as it is for lesions like this. Primary tumor, inflammatory lesion, or an atypical benign lesion. Martina, could you explain the hemangiomas? They can be poor echogenic.
Well, echogenicity is always related to the surrounding structures. So if you say you have a hyperechoic lesion in the liver, then it's related to the surrounding liver parenchyma. But if you have a severe diffuse disease of the liver, like severe steatosis, then you can see hemangioma which is hypoechoic, because it's always in relation to the surrounding structures.
I think that makes it clear, and maybe this is, before we go to the next case, we should have a little look to some additional remarks to the liver. So we had comments to the FNH, but as well we should have a look to the cyst. On the left side you see the classic anechoic appearance of a simple cyst. There are some little gray echogenicities within the cyst, but at large it is black. And there are cysts very important to be detected by sonography. I don't show you now an echinococcal cyst in sonography, but it is then present if you see any kind of calcifications like in this CT. So cysts are important. If an abscess could be questionable, and if there are calcifications, think of an echinococcal disease. We had a difficult kind of hemangiomas, and this of course has to be done if we want to present a workup. The case I have shown about hemangiomas is from the routine from last week, but in the book, as well as with other examples here, you see the classical appearance of optimal hemangiomas. If you see hemangiomas like this in a healthy patient, you just advance with a follow-up, and only if the hemangiomas exceed the size of about 3 centimeters, then a workup with CT and MRI is usually done. And I think we should give a little time to comment how hemangiomas look like in CT.
And you can see here two figures in the axial plane. It's computed tomography, and the patient received intravenous contrast media, and on the left you can see the arterial face. You see the lesion in the right lobe, a rather large lesion, and you can see that the rim of the lesion shows very, very small hyperdense margin, and on the right you see a later phase, the portal venous phase, and there you see a typical increase of the contrast media with a centripetal enhancement, which is typical of hemangioma.
So it is very difficult, very important to have a dynamic investigation.
There's a question to the echinococcus cyst. Why was there calcification? Is that typical, and how does it come?
It is typical for echinococcus cysts to have shell-like calcifications, and this comes from the cycle of the echinococcus, because these animals die within the liver, and this together with the reaction of the compromised liver tissues is leading to these calcifications, and this is very classical. Of course, you may have a post-infectious cyst, pyogenic cyst of another entity, but you always have to rule out echinococcus. So if you have multicystic disease with septae and these calcifications, always you have to clear up for echinococcus disease. And as you know, it is not wise to make a biopsy there where echinococcus is suspected. When we move on from the hemangioma, here we have this from the MRI view.
It's also a typical hemangioma, and you see in the middle figure, you see it's a two-way sequence, and you know hemangiomas are blood-filled structures, so the fluid is white on T2-wave images, and on the right there's also a figure after intravenous contrast enhancement, and you also see, comparable to CT imaging, the peripheral contrast enhancement in a later phase.
Another example.
With a smaller hemangioma, and also in this case you see the centripetal of nodular enhancement pattern, which proves that it is a hemangioma.
Okay. The focal nodular hyperplasia already was discussed. Again, here we see a beautiful CT example of it.
With the central scar on the left image?
Yeah, the left image with a beautiful, strong hyperdense central scar. But there should not be a tutorial on liver disease without the hepatocellular carcinoma. One of you would like to describe that?
Well, there's a CT scan with 3 pictures where we have a diffuse hyperdense mass in the liver with which is at all clearly shaped in the round part, but completely diffused, capsuled. If you combine it to the benign lesions we have. And of course you need to also look at the patient history, what was present there. Just from this image you can suppose it's a malignant disease, and yeah, that's my comment.
I would like to add that the very characteristic findings of malignant disease is hypervascularity. So you see in the arterial phase it's hyperdense, and you have to see the washout. So in the portal venous phase it's the hyperdensity is not seen anymore, and this is highly suspicious. Additional to the findings we've heard already of malignant character.
This tumor we just have seen, this huge hepatocellular carcinoma, we see it in sonography. It looks of course different, but as well it would be a big mass, inhomogeneous, of mixed densities, and immediately go for MRI or CT workup. So I think it is worthwhile to come back to the metastasis. It's very important to see one quality of metastasis. They are multiple. Metastases with a halo have a distribution over both liver lobes in many cases, and this is much rarer in hemangiomas. And this CT, maybe you would like to comment, is very typical for metastases.
Yes, you see, as Peter said, multiple lesions, and you see a target sign or a bullseye lesion sign, which means that the rim that consists of the compressed liver tissue has a different density than the central proliferating part of the lesion.
Again, we see that the ultrasound is in the first line, and then we move on to the more descriptive and more accurate cross-sectional imaging techniques. Here there are 4 beautiful examples of metastases, beautiful because of the composition of the most important types. The right upper image shows us bullseye lesions as well. You can see them in sonographic documentation. The left lower metastasis is a metastasis with a typical echo-poor halo, as well as the lower right multiple lesions. So I think that we have had a good overview of liver tumors, and should now change a little bit the prospect and go back to our case tutorial. So
may I say one comment to the border of this lesion, because many colleagues said there was a sharp lesion. We identified it was an unsharp lesion. So if you mind the cyst we showed first in the book, this was a clear margin, a clear line, which is a sharp lesion, and if you combine it to that we'll show you now, you see that it's in contrast to that an unsharp lesion with a hypoechoic mass inside.
Yeah, this is a good comment, so that everyone has the opportunity to keep in mind this is a sharp lesion. This cyst in the left image is a classical anechoic sharp lesion.
We have 2 questions left concerning all the images we saw. The first one is there a general rule when a metastasis is hypo or hyperechoic?
No. There are some indicative signs. Colon metastases are very often hyperechogenic with the halo, and there are cystic metastases from ovarian cancers, and there are multiple very small metastases from neuroendocrine tumors, but at last it is unspecific, it is indicative, but we don't have a rule.
Okay. And the last question is, if you combine the echogenicity from the liver to the kidney, is it always possible, or are there kidney diseases which don't allow to combine the echogenicity?
It's exactly like this. When there is a kidney with a high echogenicity because of chronic renal failure, then you take possibly the spleen to compare. But as I remember myself in such cases very often, you reflect more the remembrance you have from former cases if you do not succeed in direct comparison within that patient. This is not really a big problem because echogenicity of the liver is not a quantitative analysis, but it's much more difficult in the other way around. If you want to predict kidney disease, then it's a problem, especially in young patients, because young patients, they are not so, they don't have such a big tendency for a fatty liver. Maybe nowadays it's a little bit worse, but usually the young people have a more hypoechoic liver, and the difference between kidney and liver is then not that big. So this remains sometimes a problem. Is there any question left? No. If there is no question, then we change from the gastrointestinal tract to the kidneys. So our case 3 is again a female, young female, routine exam, and the kidney is a parenchymal organ, and the kidney size should be around 10 centimeters in adult, but this is really the most, the largest diameter you can document. So if you have a kidney with 9.5 centimeters, almost always you can reach 10.2. So the maximum, really the maximum diameter has to be 10 centimeters. But this is quite a good, outline for normal kidneys. There are healthy kidneys. They can be pretty small if it is a variant, because people can have smaller kidneys. This is sometimes a little bit difficult. Then the shape and outline, as for all organs, is very important. The outline should be smooth. The echogenicity we already have discussed here in a younger patient. We see that the liver is only a little bit more echogenic than the right kidney. That means the kidney has a normal echogenicity, a dark gray hypoechogenic appearance with smooth borders and a normal broadness of the parenchyma. And there are the pelvic calyceal area. This is this hyperechogenic part in the middle, consisting of vessels and of the urinary system, the pelvis and also the calyces. So we look for tumors, cysts, hydronephrosis, whatever, and we see here again a pathologic finding. We look for the surrounding structures, free fluid, and in more dedicated investigations, of course, we can have, we also can investigate the vessels. So other suggestions for these lesions?
Okay, one says that it's a cyst, another one says it's a central scar with oncocytoma, hypernephrosis.
A cyst should be anechoic. Even a cyst with acute bleeding would be very, very rare to see it in a hyperechoic. So a cyst can be somewhat ruled out. The other suggestions?
No, at the moment.
Well, there's no hydronephrosis.
No.
Perhaps a tumor?
It's a good idea, because it's not anechoic, so it should be solid. And if it is solid and if it is in the kidney, then we are always afraid. There's a reflex of diagnostic experts or diagnostic sonographers always to cry for urologists if there's a mass in the kidney.
Next ideas are lipoma, or
I like to hear
Wilms tumor, or angiofibroma.
Okay. Wilms tumor is a little bit late for 37 years. They're usually in children. And what I like is the idea of a mesenchymal lesion, where it is a question, does it have to be a tumor, or could it be something much more calm than a tumor? There's something in the body which is in a kind of, in a group between tumor and something else. So, but we had already some good suggestions. So let's define this local pathology. It's a parenchymal lesion. It's a mass of the lower pole. The size you cannot see, but I tell you it's 3.5 centimeters. It's hyperechoic. It's well delineated and more or less homogeneous. I like the suggestion of a central scar, as we sometimes can see that in oncocytoma. It's always spectacular cases, but in this case we may call it homogeneous. So if we have a hyperechoic homogeneous mass in the kidney, this is very common, but when very common, they are usually a little bit smaller. Usually they are around 1 centimeter or 50 millimeters. And how would you call that lesion?
Another suggestion is that it might be an abscess.
Well, abscesses are not so homogeneous, not so well delineated, and rarely you would expect a hyperechogenic abscess. What you both of you would comment as an inflammatory lesion here?
It's too well delineated, and echogenicity, as you said, is not typical for an inflammatory process within the kidney. So it seems to be a solid lesion.
Okay. So let's move on. So this lesion, well delineated and homogeneous, the lower pole of the right kidney, is very suggestive for angiomyolipoma. This is very classical and much more classical if it would be smaller. And this typical lesion can be proven to be benign in what circumstance? What is the next investigation we would do?
I think the best investigation would be an MR, because then you can, with specific sequences, you can prove fat within this lesion, and then you know it's an angiomyolipoma. If it's well delineated and it has homogeneous contrast enhancement, then you know it's an angiomyolipoma. And ultrasound is a perfect tool for controls, because you know these lesions may show bleeding, and if they grow and if they have a certain size, then you have to treat them, because otherwise you can have a terrible bleeding.
Okay, we will have a look to the workup of such lesions in the book, but before that we would like to see other renal cases. So here we have the next lesion. This is not a small lesion, it's a big lesion. You see the arrows, you see the liver, you see the kidney with a normal size, and the shape and outline of the kidney is somewhat normal. Beside these huge lesions, the ventral part of the kidney, sometimes it is difficult to tell exactly that the lesion comes from the kidney, because this is the area where we often see lesions from the liver, the kidney, or the adrenal gland, and that can be difficult. But in this case, it's a kidney lesion. And the criteria, we already had heard about cysts or benign lesions as the angiomyolipoma. This is the classical benign lesion. What would be the suggestion here?
There's one suggestion that says it's a parenchymal tumor.
Which one?
I don't remember. There's another suggestion coming in that it doesn't seem benign, points to RCC.
Okay. So, any comment?
Well, if you compare it to the figures you've seen on the other case, you now see that it's not very delineated, but it's rather lobulated, and you should also have a look at the capsule of the kidney. So can you see the capsule around the whole organ, or does it seem to be somehow disturbed, interrupted, infiltrated?
If I would.
Disturbed.
Yeah, correct.
You can see the perirenal fascia.
And of course, everybody should have a look to echogenicity of this lesion. So is it rather homogeneous or inhomogeneous, which also helps for differentiation.
Okay. So when we put everything together, we have a 7.5 centimeter mass of the ventral right kidney with irregular margins. It's well delineated at last, even if it is irregular. It's hypoechoic and inhomogeneous. And as we have heard, as differential diagnosis, there was renal tumor. And
there's another idea coming in angiomyosarcoma.
It's a very good idea, of course. It's a rare tumor, but the sarcomas, because they grow so fast, they are happy to present with a huge size first. But at last, of course, the most common tumor is the renal cell carcinoma, and this was in fact the case with this lesion, but the differential diagnosis, the colleagues in the chat, was very good. So we have had a benign renal tumor, we have the classical malignant renal tumor, and so we have to see a rare tumor. This is the rhythm. And now we see something. You see, this is not a very young sonogram, but the only I have from this kind of disease. A disease which is known. You know the disease when this person enters the room, and almost always they have a lot of history and exams with them when they enter the sonographic unit or the CT or the MRI. So which disease could be behind this appearance? But let's go back to the kidney. Well, let's say the kidney size is normal. What is the shape and the outline? Any comment of the shape and outline of the kidney, the whole organ?
not sharp.
Yes, because it's an old image. But
It's kind of cirrhotic.
it's a cirrhotic kidney. This is new. So somebody is making history. Kidney cirrhosis. It's not a bad term. Why not? But anyway, this the main finding is the local pathology. So we have something to see here. What do we see? How we could describe this appearance compared to a normal kidney?
It says that the outline is a little bit disturbed and there are many hyperdense lesions.
I like this suggestion because I think the colleague wanted to say hyperechoic lesions, because hyperdense would be CT. But maybe an old CT machine produces pictures like this. Who knows? But it's a multiple hyperechoic lesions in this kidney. And asking you what this could be, well, this is just, oh, sorry, sometimes the things went wrong. This is multiple rounds and they are suggestive for angiomyolipomas. I just advanced and I gave you the hint for the disease, and I'm not unhappy with that because we have to move on for the time. This is the classical appearance of tuberous sclerosis, which is a phacomatosis, and that are multiple angiomyolipomas. What is very important here to state for basic sonography is that these are not stones. If you would see calcifications with this size, you would have a strong shadow, and behind the kidney you couldn't see anything. So these little rounds are multiple angiomyolipomas. In a rare disease, tuberous sclerosis, these people enter the sonographic room with their skin manifestations, with multiple lesions in the skin, and here you see a beautiful CT image of the fat-containing fat-containing lesions on computer tomography. So in this setting, we would like to go back to our book, our clinical textbook of radiology, and we would like to step a little bit to these tumors and other examples. This is the complete chapter. Here we see a beautiful example of a normal echogenicity of the liver compared to the kidney. This is in middle-aged people, the classical appearance of the kidney, and in a cross-sectional view you see the vessels in the direction to the great median vessels, the vena cava and the aorta. So here you see what sonography can depict with color Doppler. You see the main vessels of the kidney, and we could show you many interesting cases of the variants, hydronephrosis, and we will have another tutorial where we will include stone disease. But as I showed you, that angiomyolipomas, they don't have a shadow. If you have a calcification in the kidney, it is very important to know that there is a strong shadow because the beam, the ultrasound, cannot traverse through a calcification will be totally reflected, and behind the calcification you see a shade, you see no heterogeneity, and this is the sign. So very common and very important are renal cysts. You will find them very often, and they are like liver cysts, completely anechoic round masses in the kidney, and they can be cortical or in the pelvocalyceal area, and then you have to care not to mix them up with hydronephrosis. And in some kinds of disease you might meet the polycystic kidneys, but we don't have time to concentrate on this. Here we meet again our angiomyolipomas. And here we can see proof of fat in a CT image, which is shown as a hypotense area. Very important if you have a renal tumor, a malignant renal tumor, as we just have seen. You see our tumor here, the lower margin of the image, is to have an orientation if this tumor is crossing the capsule and invades the periphery. As well, it is very important to look whether there is a tumor thrombus or not. Even in sonographic investigations, it's possible to look for the vena cava in the pathway through the liver, and these are sometimes valuable informations before the further workup. I think this is quite the perfect time to move over to our quiz. We have now seen liver and renal cases, and in the end of our webinar you can win books, the clinical textbook of radiology, or from Alexander Sachs, who has written a basic book on sonography of the abdomen, where you can enter the field. And you could look on our homepage of the publisher, University Publisher 3.0, where you can, for those who didn't win the book, they can get the book over the page. So the first case of our quiz is a chest X-ray, but has to do possibly with the both organs. One of them maybe we have had during this webinar. So what's abnormal in this chest imaging? We open the chat and we close the chat after a certain time, because we will solve the cases within this webinar. So try to make a suggestion for this case. What is abnormal in this case? The lung and the heart are fine, but we're interested in the abdomen. I like the left diaphragm, but I don't like the right one. Are there any candidates eager to solve this case?
So before you said everything is fine in the with the lungs and the heart, there were several diagnoses about cardiomegaly, lymph nodes.
This is an Austrian heart pumping to get rid of a huge belly, and it's a left-oriented hard but not really big. And this patient is not a good breather.
But now there are coming some ideas about the right diaphragm, what that could be. For example, a hernia, or
Yes.
a liver cyst, or a lesion of the right superior lobe near the superior vena cava, hepatomegaly, and the last idea is the Chilaiditi syndrome.
I like these colleagues who have so good contributions in our chat. So I would say we go to the second case. It's very easy because you saw this image possibly. Benign, malignant, is malignant, which kind of disease? I think it's easy. This was the easy case. The first one was the difficult case. Are there some ideas in the chat? You think so? And this is an eye catcher. I didn't speak about the image. It was running through. It's from the book. And it's as well a very classical thing. So I go back, quiz case 3, quiz case 2, quiz case 1. The 1 was the most difficult, of course. Do you think it's difficult? Well, Martina and Alexander, both of them are teachers in radiology, and they every month have newcomers, and I would say every third newcomer will see such this diagnosis. And do they catch this syndrome?
Often not, but if you've seen it once, then you know it.
Of course, but if you have seen it never, it makes troubles. And when we will open the quiz, or we will close the quiz, and I will explain you the diagnosis, I will tell you the story how the name comes from. Yeah, and this is the second quiz case, and the third one. The last two are pretty easy. So I would say the master of the chat, Alexander Hirsch, will close now the case, and no more, nothing is possible. It's like in Monaco.
Yeah.
Okay?
Right. Okay.
It's like in Monaco. And now I'm happy to present the first case. It's the famous Chilaiditi syndrome. What the European Union was not able to do was to make an alliance with Turkey, but in the beginning of the 20th century, a famous Austrian radiologist, which is called Guido Holzknecht, had a Turkish resident, and this was Mr. Chilaiditi. He was not very interested in research, but he came up with this image to Mr. Holzknecht, and he was very affected by the fact that there are lucencies below the diaphragm, and this is air. It cannot be a cyst because it is air, it is gas at last. And then Mr. Holzknecht did a lot of things. I don't like to know what he tried or what he had to do to find out what it is, but this is the famous interposition of colon between liver and diaphragm. And Holzknecht helped Mr. Chilaiditi to make the case report, but he was the first author, and so it's the Chilaiditi syndrome, and he's much more famous than his teacher. It's very, I like this case because Mr. Chilaiditi had one paper in the world, and everyone knows. And but it's an important syndrome. I like to present it in basic radiology. Why? I like to present it because if you have a Chilaiditi syndrome, you never should undergo a liver biopsy. Very rare, of course, the combination of Chilaiditi syndrome and liver biopsy, of course, but then it can be a deadly perforation of the colon, because here you cannot perform a biopsy, so it's not an unimportant thing. And easy to detect, bubbles below the diaphragm.
And you can have clinical symptoms. That's the reason why it's called Chilaiditi syndrome. So you can have observation or some pain
Yeah.
the right upper abdomen.
2 liters of Coca-Cola can make really problems to breathe.
Yeah.
I imagine that. I imagine that. So, well, we had these examples of metastases from the book, and these are classical metastases of the liver, multiple lesions within poor echogenic halo, and in this case, in a somewhat fatty liver. And the third case, just to make it as clear as possible, these are typical cysts, anechoic masses, well-defined, very sharp outline. These are liver cysts. So at this point, we are at the end of our webinar, and thank you very much for your attention. And in the name of my colleagues and the team, I wish you a good time up to the next webinar. Thank you.